Continuing mobile education for emergency medical services providers. This is Procedures in Geriatric EMS, Episode 3, Airway Management. At the end of this episode, you should know the indications for intubating the older adult in the pre-hospital setting, be aware of special considerations for the intubation of geriatric patients, understand proper technique for ventilating an intubated older adult in the pre-hospital setting, and review BLS airway device use in older adults.
The indications for intubation are essentially the same for older adults and younger adults. However, I think anyone who has even a little experience knows that the older patient is far more likely to need to be intubated for conditions that we just don't see in the younger patient. Things you need to be aware of in the older patient is that the oxygen reserve is much lower. This is for a number of reasons. One, they may not have the carrying capacity within their hemoglobin as they get older. Number two, the heart is greatly affected, and you do not have the strong heart that you would in a younger person. Therefore, they cannot compensate when they need more oxygen. Other things that may happen in the older patient is clearly we know that they have many more serious problems that may require intubation, such as problems with their heart, congestive heart failure, as well as their lungs. COPD is obviously much more common in the older patient. So you need to have a much higher level of suspicion and intubate earlier in the older adult because they will decompensate much more quickly than a younger patient.
Older adults cannot tolerate decreased oxygenation because they have decreased respiratory reserves, decreased oxygen carrying capacity, a less efficient cardiovascular system, and individual patients can have multiple respiratory and cardiac comorbidities.
The indications for intubation are the impending respiratory failure, the decreased level of consciousness, the general rule of less than 8 intubate, referring to a less than 8 on a Glasgow coma scale. You need intubate, that always applies. And you begin to judge how much of a struggle that person is having breathing. I think it goes without saying that a person in respiratory arrest or cardiac arrest needs to be intubated. But we should also remember we have other tools for managing that airway. If they're in cardiac arrest, there's a lot of research that's showing that we want to make sure we're doing that chest compression, so we don't want to take a lot of time to intubate. So consider an alternative airway like a King airway or a combi tube so we're able to place it quickly. But for an adult that's breathing, remember it's a last resort to intubate. So let's consider, is oxygen, high flow oxygen alone going to be enough? Is the CPAP going to be enough? And if we get to that point where we decide, yes, absolutely, CPAP's not working, the high flow oxygen isn't working, I need to intubate, make sure you have all the resources available, consider whether or not you want to go through a rapid sequence induction to intubate the patient.
Clearly, we look at several things in any patient. One is the ability to protect the airway. Two is inadequate ventilation, and I need to talk about that a little bit more. Inadequate ventilation is not just the SAT, but it can also be the amount of carbon dioxide. So both of the main indications, protection of the airway and provision of ventilation, are much higher in the older adult. In addition, the course of how the patient is going to do must be taken into effect. If you have a questionable airway in an older patient and it's going to take longer to reverse the cause that is causing them to have problems with their airway, it is far better to go ahead and intubate them so you're not having a long drawn-out course where you're worried about their airway, whereas in a younger patient it may turn around much more quickly. A couple of the pearls that I would like to impart on this is that we traditionally have used the gag reflex as an indication for intubation. This is not a good indication of whether a patient is able to protect their airway, as studies have shown that up to 30% of patients that are awake and normal do not have a normal gag reflex. The two things that I would like to have you look at are, number one, can the patient control their secretions? Are they drooling or are they pooling secretions? And that's another thing you will find when you use one of the oropharyngeal pharyngeal airways, and are they able to speak? Those are the two best indications whether they have intact protective reflexes. Other things are that the older patient is going to get much more tired if they're working hard, say with CHF or COPD, and you must anticipate intubating them before then, because once you lose their ability to ventilate, it is a crash airway. That's a very dangerous situation, and even short periods of hypoxia can lead to very serious problems with outcome in the older adult.
Indications for intubating the older adult include failed BLS airway attempts, cardiac arrest, impending respiratory arrest, inadequate ventilation, a GCS score of less than 8, and airway protection. For example, a patient who cannot manage their own secretions. The absence of a gag reflex is not a reliable indicator for intubation, and you should anticipate the need to intubate older adults who have been working hard to breathe for extended periods of time.
When you're actually ventilating a patient, an older patient, you need to be concerned about what is their lung compliance. If you may have somebody who's got a long history of lung disease, and it may be more difficult for you to ventilate. So it'll be physically harder to squeeze the bag. And it's difficult to know, is it harder for me to squeeze the bag because I've just created a pneumothorax? Or is that what their lungs are normally like? So it's probably wise, particularly in a patient who's just in respiratory arrest or respiratory failure or tract breathing for them, to have a very experienced person managing that bag valve mask so they can get comfortable and they realize, okay, it's more difficult for me to bag than it was, or everything's going nice and smooth. If we haven't gotten to the point where an advanced airway is in place, the mask seal can be challenging, particularly if the patient has dentures and we've removed them, which is appropriate. It changes their facial anatomy, where it can be difficult for us to get a good seal around their mouth. So you need to consider, should I be using a blob mask? Should I be using, am I using the right technique, the EC technique, to make sure that I'm getting a good mask seal with what I have available to me?
When ventilating older adults and you're doing a bag valve mask, there are many changes that you need to be aware of to maintain proper ventilation. When you have a patient with altered mental status, we know that they are far more likely to occlude their airway. One of the things that we were always taught was, when intubating, take out their teeth. It's much easier, and that's true. However, when using a bag valve mask, you need those teeth to maintain the proper anatomic alignment within the mouth. So leave the teeth in unless they are impeding your ability to ventilate. If you have a person where the dentures are a problem and you cannot keep the dentures in, remove the dentures, take a 4x4 that is folded up and insert it into both cheeks, which distends the lips and the airway and will make it easier to ventilate. With the older patient, as we have talked about, they lose their ability to maintain tone in the airway. Therefore, basic positioning is incredibly important. I cannot tell you how many times when I've been called to the trauma bay to assist in an airway where they say they cannot bag the patient when the solution was basic BLS maneuvers. Chin lift or jaw thrust absolutely makes all the difference in the world. We use this more than any other airway technique. It is the most basic but the most important. When you're bagging also, particularly with an older patient with COPD, you may need to use higher intake pressures but allow for adequate exhalation. You may ventilate at a lower level. We get all excited, I'm in this boat, and we want to crank the bag and hard and fast, but take your time. Slower is better. Give them the chance to exhale and listen and find out, are you having stacked breaths? Are you trapping air within the lung? Because older people are far more prone to, as we would say, blowing out a lung, getting intention pneumothorax, which is a life-threatening situation. So be very careful with your pressures. The other thing, something we don't normally think about, is if you have the ability to adjust the amount of air in the cuff of the mask that you're using, use that. In one study, they found that of patients they were having difficulty with bagging, 50% were due to a wrong pressure within the mask. So see if you've gotten a good feel. Make sure that the mask is properly placed and that it is properly sized. I can't tell you how many times I've seen a nurse run up with a pediatric mask for an adult patient, and it's no surprise when you cannot ventilate that type of patient. And always remember, with the mask, it's better to go larger than it is smaller. The mask needs to completely go around the entire mouth so that you do not have an air leak.
When using a bag valve mask, the chin lift jaw thrust is a basic but important maneuver to open the airway. Leaving dentures in can help improve BVM success. Adjusting the size of the mask may improve your success, and allow for adequate exhalation and make sure you're not trapping air in the lungs.
The indications for placing a nasopharyngeal airway and oropharyngeal airway in the older adult, again, are the same as for a younger patient, but there are several things we need to talk about that are far more common and important in an older patient. As we age, we lose the ability to maintain tone in our airway. And when you start to lose consciousness, and this may be indicated both by the level of consciousness of the patient or when they're working very hard to breathe, you may lose the ability to keep the airway open. Therefore, you have a much lower indication for placing a nasopharyngeal airway or an oropharyngeal airway in the adults, because they are much more, older adults, because they're much more likely to occlude their airway earlier and with less provocation than in a younger patient. This is particularly true if you're giving any medication for sedation. You may go from having an intact airway to not having an airway at all with even a little bit of pain medication or sedative medication. So therefore, I would strongly recommend that you consider using some type of airway adjunct far earlier in the older adult so that they don't occlude their airway, usually by their tongue or loss of tone in their airway musculature.
When it comes to managing the airway in an older adult, one thing to keep in mind is, what are the patient's wishes? Do they have any advanced directives filled out? Do they have a MOLST form? Do they have a living will? Do they have a do not resuscitate order? So you want to make sure you know that status before you get into the situation of then, okay, I may have to do some advanced airway skip. Even if they have an advanced directive, it's usually not a do not treat, but a do not resuscitate. So if the person is in respiratory failure, we still have to treat that respiratory failure. It only comes into effect when they go into respiratory arrest. So we would track breathe for them, or we would intubate for them if it's appropriate. They don't have a written order against it. Remember the fact that once they are intubated and put on a ventilator, it's going to be difficult to wean them. So we don't want to get there unless that's the difference between saving their life or having them die. So once we make that decision that they truly are in respiratory failure and we need to manage their airway, then we begin to go about it with all the tools we have in our tool belt. So the CPAP, the advanced airways, and intubation.
Pre-hospital care providers need to be far more aggressive in airway management when working with an older adult. As we've already talked about, they lose their reserve much more quickly and have less ability to maintain their airway for a number of reasons. Therefore, several things need to be looked at in the older patient. As we talked about before, are they getting tired? But more importantly, what is the status of their level of consciousness? One of the first things that we will see when an older patient is about to lose their airway is that they will either become very anxious or more likely they will become less responsive. When you start to see a patient become less responsive or a paradoxical decrease in their respiratory rate when you would normally expect them to be tachypnic, you need to be thinking about intubation or using some type of airway adjunct. Other things to watch very closely are the SpO2, the amount of oxygen in their blood. As we talked about before, older patients have a less reserve and at a lower level will have less time before they start to go into shock. and severe acidosis, and so you need to be far more aggressive with intubation in that circumstance. Other things that you will see more often in an older adult, such as sepsis, where you may need higher levels of oxygen and be offloading CO2 more likely, are again far more common in the older patient, and we know that any older patient that has an altered metastatus, sepsis is in the differential. So you need to be far more aggressive in managing the airway, both from a BLS as well as an ALS or intubation standpoint. Moving on along that line, there are special considerations when placing a nasopharyngeal airway or an oropharyngeal airway, and as well as intubating the older adult. When you get older, the skin, the mucous membranes of the nose and mouth and oropharynx change. You become much, much more prone to bleeding. So excessive manipulation of the airway can lead to a disaster, both from a non-invasive and an invasive standpoint. When placing a nasopharyngeal airway, it is even more important in an older adult to try and fit the nasopharyngeal airway to the patient. If you're having trouble placing the airway, and make sure you use as much lubricant as you need, try the other nostril. Usually it's the dominant nostril, the right side, that's larger, but not always. Oropharyngeal airways are even more of a challenge because of the bleeding risk. If you insert them backwards and you scrape the top of the hard and soft palate, you can increase their risk of bleeding and the amount of swelling, making it again a crash airway and losing the airway. So be very careful. Always use a jaw thrust or chin lift maneuver when you're placing the oropharyngeal airway to maintain tone of the tongue so that you don't get the tongue caught between the posterior oropharynx and the oropharyngeal airway.
Older adults are more likely to need a nasopharyngeal or oropharyngeal airway than younger patients. Mucous membranes become more fragile with age, so be careful of bleeding or swelling during nasopharyngeal or oropharyngeal placement, and use a jaw thrust when placing an oropharyngeal airway.
When intubating, it is clear that we need the best intubating conditions that you can. Therefore, in the sickest patients where you have the least amount of time to get the tube in, you need to have the best intubating conditions. Consider RSI, because you will need less attempts and be far more successful when the patient is properly prepped. This includes such basic things that we forget, like positioning. Make sure you have another person, a BLS person, to be able to maintain the sniffing position and to be able to maintain pressure, the burp technique and Selleck's maneuver, because those can increase your ability to intubate by 1 full grade, which is very, very significant. So the combination of a good helper being able to maintain the proper positioning of the airway with the right medications to prep the patient properly and an experienced intubator is your best chance for getting a definitive airway and saving that patient.
After viewing this episode, you should know the indications for intubating the older adult in the pre-hospital setting, be aware of special considerations for the intubation of geriatric patients, understand the proper technique for ventilating an intubated older adult in the pre-hospital setting, and review BLS airway device use in older adults.